Welcome everyone. Thank you for joining us this evening for the third session in our End of Life in Primary Care webinar series. So thank you and welcome. I'd like to acknowledge that we're meeting on Ngunnawal country and pay my respects to the Ngunnawal people as the traditional custodians of the land in which we're meeting on, and pay my respects to the elders past and present. And I also extend that respect to any First Nations people joining us today. Thank you for joining us after a long weekend and school holidays and daylight saving all collided all in the same weekend. So thank you for joining us. So far, we have had 2 sessions looking at the end-of-life law for clinicians in ACT, and then discussions around end-of-life advanced care planning and the documentation for ACT. So tonight we are focusing on palliative care in the primary and then the specialist palliative care settings, the resources that are available to you working in the primary care setting and the services available to your patients in ACT. I'd like to start off by introducing Louise Kenyon. Louise is a GP, plus she's a clinical lead for the Health Pathways program here in ACT. Louise is going to introduce or refresh what Health Pathways is and how they can be used to support your palliative patients. I'm going to stop sharing my screen now, and then Louise will take over. Thank you. Just work out, stop sharing. There we go. Thanks, Louise.
Hi, everyone. So as Roz said, I'm Louise Kenyon. I'm the clinical lead of the ACT and Southern New South Wales Health Pathways program. I'd like to also acknowledge the Ngunnawal people, their elders past, present and future, and the beautiful land that we live on here today. So one big change with Health Pathways is that we've changed the branding and we've changed to personal accounts. The advantages of the personal accounts is that it allows you to do a smart search and which gives you more of an in-depth search of the pages. It also allows you to create notes and keep a CPD log. So you can see on the side here, you can add learning and then create a CPD report for a certain time period. It's just really useful when you are low on your CPD hours. So I think everyone knows what Health Pathways is, but the reason why we exist is to try and support clinicians and integrate the healthcare system. We give advice on for GPs on how to assess, manage, and when to refer and who to refer to. We have resources for both clinicians and patients. We have map services to help find services that are local to you. And we also include in that the service referral criteria just to help your referrals be more successful and not get that reject from HealthLink. This is the palliative care table of contents at the moment in ACT Southern New South Wales. If you want to get to here, you can just put in search palliative care. Of these, some of these link off to actual pages. So advanced care planning goes off to a page that's just about advanced care planning. Emergencies in palliative care is a tree page, and it goes off to a page that gives you a number of different palliative care emergencies, and the symptom control in palliative care is another page that goes to a number of different topics. I'm just going to show you the raised intracranial pressure page. We've been trying to streamline our pages more. So as you know, Health Pathways has been around for 10 years. And with that, we change in styles. We're constantly reviewing our pages. At the moment, we're reviewing all the palliative care pages, and we've got 5 of them live at the moment. So any feedback you have on the pages, now is a great time to send it. So you can see that when we say examination, we don't say do a neurological examination. we show that, just the really important features for raised intracranial pressure. This is called a drop box, and what I've done is I've clicked on that word examination to show the details. When we're structuring the pages, we really try and balance between clicking and scrolling. We don't want to hide too much information in drop boxes, but we also don't want to have you get RSI from scrolling through a page over stuff that you already know and don't need. This is, I've skipped to management, and it just letting you know that we're not a textbook. We're just trying to give a point of care resource with the absolutely essential information. So here I've expanded the corticosteroids. We just clearly say, give them immediately, don't wait for imaging results, and exactly what to give. If you need information about adverse effects and interactions, then unless there's something very significant and unexpected, then it would be going to your normal source of information for that. Then what's unique to Health Pathways is that we have the referral section that links to our local services. So Emma's presentation may have, well, I think we should have all the services. If there's any holes, then what we do is we go back and we update it. The platform can be quite responsive to that. So you can see that we haven't just told you to do a whole lot of stuff. We're giving you all this blue writing links to a page that tells you how to contact that service. So here I've gone to, oh, sorry, before that. And then at the end of the page, we have a very curated set of links off for information for health professionals and information for patients. We try really, really hard to have our Aboriginal and Torres Strait Islander and English as a second language resources link there, because they can be just so difficult to find. It takes us ages to find them, and we try to get the most appropriate ones there. So the Aboriginal and Torres Strait Islanders, if this box was closed, all you'd have was those little flags letting you know that there is in fact an Aboriginal and Torres Strait Islander resource, and this is the English as a second language, culturally and linguistically diverse. So here is the palliative care referrals page. We've got a number of different services. So we've got referral into the acute services, but we've also got the community supports and how to refer to the voluntary assisted dying, how to get into the loans and purchase of equipment. As I said, we're a really responsive platform, and we really, really like you to send feedback. It's really helpful for us to know what you want on a page, what's missing, if you feel like something's wrong. And a lot of people shy away from sending feedback. They don't want to be that cranky old man. Just like to say that we're very happy to receive it. Thank you.
Great, thank you, Louise. That's a great intro. I forgot to say that we do have a Q&A box where you can ask questions. Is there any questions for Louise? Feel free to pop the questions in as the presenters are talking, and then we will address them either during the presentation or at the end of the presentation. So have we got any questions around Health Pathways? I can reinforce what Louise says about the platform being responsive. We did have a GP contact us about something that they were finding confusing in Health Pathways, and we were very quickly able to rectify that with the team. So thank you for that. Any questions or comments? I can't see any. All right, thank you. Thanks very much, Louise. And as Louise mentioned, Louise's team is currently reviewing all the palliative care health pathways at the moment, and hopefully aim to have those done by the end of the year or near after. Thank you. So next we have Dr. James Manley, And James is a GP plus a GP policy advisor for the Office of General Practice and Primary Care at ACT Health and Community Services Directorate. James is very proactive about general practice using MBS item numbers as best possible. So I will hand over to James. Thank you, James.
Thanks, Roz. I'll just get my slides up. Yeah, the new directorate is a bit of a mouthful. I prefer the directorate, formerly known as Health, but they haven't taken that name on officially as of yet. But let's see how we go. So anyway, yeah, as Roz said, I'm James. I'm a GP. I work in Denman 2 days a week, and then as Roz said, I work at the Health Directorate 2 days a week as well. And yes, and if anyone has met me already, then I've probably already talked to you about MBS item numbers, for which I apologise. But I suppose this is the reason I'm here tonight, so we can dive in and hopefully there's some useful information around in this. And you know, I don't know if I can fix remuneration in this particular sector, but hopefully this can give you some ideas on how maybe it can be remunerated a little bit better with the item numbers available. So we'll go in, and I thought I'd just do a little bit of just general MBS stuff, because I found this really helpful when I did some MBS learning. Just, you know, the bare basics. I think once you understand the system, sometimes learning the item numbers just on their own becomes a little bit less arduous. So, you know, eligibility. So I guess they have to have a Medicare card. They can't be admitted as a patient of a public hospital. There's a bit of an asterisk on that one because there's case conferences which can be billed for patients that are about to be discharged from public hospital, and that is okay. But in most circumstances, no MBS benefits for people that are in public hospitals. The patient and the doctor have to be in Australia at the time of the service. This seems obvious, but with the advent of telehealth, that has become a little bit more challenging more recently. And being a resident of an aged care facility changes access to certain services, so certain item numbers can't be billed for residents of aged care facilities, and we'll get into that a little bit later. For all Medicare services, the service must be clinically relevant. So the Health Insurance Act states that it can't be a screening activity. So, you know, I guess a group of your peers would have to agree that it was clinically necessary to do whatever service you delivered. But it does make a statement that a health assessment, being proactive prevention, is not screening, so does not fall under that category. Co-claiming. So I do a fair bit of co-claiming, and I think there's a lot of confusion around what can and can't be done. I think in general, the rules are that all services have to be distinct, so there can't be any overlap. So one part of something that you do can't count towards 2 item numbers, including time. And of course, there are certain item numbers which can't be claimed together. Time-tiered items. So I'm sort of referring to the standard consultation items or any item number that says a certain amount of time must be spent with a patient. So if a minimum time is stated, that time almost always relates to the amount of time the GP must be in front of the patient. So this is the time that the patient is in the room, or you are in attendance of the actual patient within the same room as them. The exception here is health assessment item numbers, where practice nurse time counts towards the time spent for a health assessment. So I guess the main thing there being, you know, after the activities undertaken after the patient leaves is not, you know, cannot count towards the Medicare criteria for those numbers. I've just got to note there on split billing as well. So if you do happen to bill more than one Medicare service on one day, it is up to you whether you bulk bill all of them, private bill all of them, or bulk bill some and private bill another. There is an exception to this, and that's the multiple services rule. Say you were to take 5 punch biopsies from a patient. If you private bill one, you must private bill all, and if you bulk bill one, you must bulk bill all. So that's the only exception to that rule. So if you do a mental health care plan plus a standard consultation, you can bulk bill one, private bill the other. World's your oyster in terms of that if you happen to be a person that private bills. So hopefully that stuff is helpful as a bit of a starter. So I thought I'd go through some of the services that palliative patients may be eligible for, and I guess depending on their age, ethnicity, whether they're in a aged care facility or at home, that will change what item numbers they might be eligible for. So I thought I'd just sort of list out the general categories. There's your stock standard consultation item numbers, but that would include in the office, at home, and then after hours and after hours at home. There's the GP chronic condition management plan numbers, the GP mental health item numbers, health assessment item numbers. There's a category of phone item numbers that are for bloodborne virus, sexual and reproductive health item numbers, which I thought could be relevant for patients that happen to have a cancer of a reproductive system, or if they happen to bring up a, another related sexual or reproductive organ thing, or if they happen to have bloodborne viruses and you need to manage those as well. There's case conferencing item numbers. As an aside to that, there's mental health case conferencing item numbers, medication review item numbers, and then for aged care facilities, from what I could tell, I did have to go into this in that one of the sheets I looked up excluded mental health item numbers for aged care residents of aged care facilities. I can't see anything that supports that, and they do seem to be eligible for everything except the GP chronic condition management plan item numbers. Their attendance item numbers are different, but there are equivalences to the 3, 23, 36 and 44s, and they can't have the GP chronic condition management plan. They're instead eligible for a contribution to a multidisciplinary care plan by a GP, which is a slightly different item number. This is probably more of a table to refer to later, in that it's a bit meaty. There's obviously a lot of numbers on here. I've tried as best I can. They're getting rid of a couple of GP mental health item numbers on the 1st of November, so I've just denoted them with an asterisk. This was meant to streamline mental health care and consultations, but I think in reality it reduces your ability to be able to co-bill some of these item numbers. So in my eyes, that's it's a shame. I wish they were staying. I actually quite like the 2712 and 2713 item numbers, as they're very co-billable with a lot of different numbers, unlike the standard consultation item numbers, but that's a bit of an aside. So I think I wanted to go through a potential consultation structure in terms of MBS item numbers. There are some pretty good examples at the link that I've got on there. Ros, are they going to get are these slides going to be available somewhere, or can we link these somewhere that people can make it a bit more clickable? Or
thanks, James. I've put the pathway to that in our group chat.
Cool.
I've put the care
I don't need
search
it.
one.
I've made my own example, so we don't actually need it, but they're a good example to refer to as well. I think they haven't mentioned any potential co-billing, so I think I probably try to make mine a bit different and to say that if you want to structure your care that way, then I think there are some potential advantages for it. They do a little bit more of one item number on one day, which is not, I think there are no wrong answers here, but I think sometimes having more on one day can allow you to extend the amount of time you get with someone for a pretty generous rebate, which I've always found advantageous in my own practice, in that I think particularly some of this advanced care directive and care planning, it's not something you want to stop and then go back to next week or later on. It's something you probably want to try and get completed, and if you've got rebates that are going to let you do that, that's good. So I made a patient up. This isn't a patient from my practice. I just completely made them up. So I was going to say they're a 67-year-old patient. I'm going to imagine that they were previously completely well and had nothing wrong with them. So you probably hadn't undertaken any of their GP chronic condition management plans or health assessments ever or previously. They're recently diagnosed with a surprise diagnosis of metastatic colorectal cancer. They've opted for some palliative chemo and radiotherapy, which has actually started. They've got some symptom burden related to this. Obviously, the diagnosis and the prognosis is a bit of a surprise, so they're very surprised at having to confront their own mortality sooner than they may have thought. They're living at home with a partner, and they would like to remain there as long as possible, and if possible. They've got 3 children, with one living close and others scattered across the country. So I suppose I chose a few of these things just to try and get a bit of a sense of what we could do. And if there's any questions or anything, or anyone wants to put anything in there or ask questions as I'm going along, I'm more than happy to sort of stop and address it, Ros. I just can't see the actual chat bar, so if you just want to let me know and stop me during it.
I will do, James.
Yeah, so I was trying to imagine this patient and how I might set it up, because I think the examples that I had, they said do the health assessment first, and I was a bit like, is that really how I'd want to structure it? And probably not, because I guess if this happened, like, at hospital, they went in sick and they came out with metastatic cancer and they'd already had some of the, the cancer teams take up, a lot of that care already, they're probably going to come and see me a little bit later in the piece, because it'll all be a bit chaotic. They'll have appointments and be seeing all kinds of other people. So they come and see me. And I think the first thing I want to do is just kind of assess where they are at. So I probably don't want to dive into like a health assessment or a care plan at that point in time. So I think my first consult would probably be, a standard item number for the next month. There's going to be a mental health component. As I said, they're probably going to be quite worried about the mortality element of it. I could co-bill a mental health item number to do that if I wanted to do the mental health care plan, because they were very distressed and I thought that, getting referred to someone at that point in time, I could undertake that with a 2715 or a 2717, 2700 or 2701 if people don't have the mental health training. And I think, billing those together, I think, is quite reasonable, and would give, I think, a long amount of time potentially to, assess where they're at, make sure that there's, is there advanced care directive, is there an EPOA, wills, all those sorts of things, all those things that people potentially haven't thought about, if it's appropriate to bring it up at that time. And I think at this consult, that's where I'd maybe bring up, hey, there's these bigger ones we can do to actually sort these things out, and we don't have to worry about the time pressure now, because we've got these health assessment item numbers where you can see the nurse for a long period of time, see me. We can set some goals about what you want, and we can, book in a good amount of time for us to do that. So I thought that, I said second week, but it might depend on what your book looks like. Setting that in, booking some time with the nurse, whatever your practice's sort of preference is, whether it's 30, 45 minutes. I think realistically, if you're doing a health assessment, it probably should be a 707. I think the rebate's very generous for 707, and it doesn't make much sense to have nurse time and doctor time available and bill less than the full 60-minute item number. And I think there's plenty of meat in a presentation like this to get through to meet the, the criteria for that item number. So you could do that, and then at the same time, I think if you're doing your goal setting, so I think that basically writes the GP chronic condition management plan itself. Then you're going to set some goals of care, you're going to set where they want to be, and you've basically made some patient-centered goals that are measurable, hopefully achievable, realistically. And so you've got SMART goals there. You can write those down, put them in a GP management plan, and you've got that there. And you can see that if you do a 707 and an I65, which can be co-billed together, 707 is not on the list of consultation item numbers that are not allowed to be billed with a care plan. That's $470 just in rebates, let alone if you private bill one of the item numbers. So I think in most GP settings, even for an hour of just GP time, that's pretty good. So they could spend an hour in front of just the GP plus some extra with the nurse that would give, I think, ample time to chew through some of the big issues and hopefully get a bit of a direction, and I think also make the patient feel a little bit better about where they're at and that they're being very well looked after as well. So then at the third week, I think if you haven't done the mental health care plan, that might be another one to then come back in and do. You can technically do that mental health care plan in that second week consult as well. They will be with you a very long time, but it is possible if you've got, if you prefer to the sort of the long form medicine, that's quite all right to do together as well. But you're probably just going to, depending on their symptom burden, you might just need to check in standard consult item number there. At that point, I've also sort of said that, depending on how many medications they're on, this might be a good time to flag a medication review and actually send a referral off to a pharmacist, whether that's, the pharmacy next door or one of the online people that offer it, or, whatever's best for that particular patient. If you actually send that off and say, here are the issues, here's what we're not managing, you've got that first part of the medication reconciliation done, and it actually has sort of set it for when the patient comes back next time. You can then bill that item number fairly easily without too much hassle and running around. So then you've got a bit of a team in place then. So if you're really keen, you could then organise a case conference with them, because you've had your GP chronic condition management plan, you might have picked a dietitian or an EP, psychologist might be involved at this point. You can then coordinate a case conference with them, and those are the relevant item numbers on that side. I think I can't remember the rebate amounts, but I think from memory, the 739 is the 20 to 40 minutes, and it's $140, I think, around about rebatable. So it's not better than it's better than the usual standard consult item number rebates, and there's item numbers that the allied health professionals can bill as well for attending those. So then when you get them back again, whether that's a month later or a few weeks later, hopefully the pharmacist has then seen them for the home medicines review. You could then complete the medication review, fax that review off to their chosen pharmacy. You can bill the 900, and then whatever you see them for on that day, you can then co-bill a 23, 36, 44, however long you actually end up spending talking about the other issues. And again, the rebate for a 900 is about $180 plus your standard item numbers. I think you're getting up into, fairly well remunerated, even just rebated item numbers. And then third month, at 3 months and 1 day, the review of the GP chronic condition management plan is going to open up. The paperwork has been streamlined since they changed these from 721 to 723. I think it is actually a fairly easy item number to meet the criteria for checking progress against goals, all those sorts of things. I would have loved to put a review mental health care plan or mental health consult item number in there, but they won't exist past November because they could have been co-billed with the 967. But again, there's not too much we can do about that. So I thought that was, in the initial point, I think that's a good way to get a lot of the meaty work done. And then hopefully you've set things up and that you're probably seeing them for episodic stuff. Things are going to go wrong. There's going to be little phases, but hopefully, if you've got an appointment booked in every now and then, hopefully you can catch some of that just in routine care. But this should hopefully set up things to be a bit stable from the outset. I think that's all I had as just a bit of an example. I'm happy to chat to people about this more if they wanted to, and we can get my contact details on somewhere, Ros, if that's helpful. But yeah.
Great. Thank you, James. I think that's really helpful information. Does anyone have any questions or comments for James?
It is pretty dry stuff, so I do apologise, but
yeah,
I'll try to make it less dry by being enthusiastic about
yeah, absolutely. James, can you see the webinar?
I can get it up now. Here we go.
Just I've put the care search resource in there, but do you want to put your email address that you
sure. Yeah.
can be contacted with if GPs want to contact you? I'm going to go straight on to Lorraine's presentation because I think that really fits nicely with what you've talked about. So I'd like to introduce Lorraine. Lorraine is a registered nurse who works at Conder Surgery as a practice nurse. She spent the early part of her career working in a hospice in Melbourne and then diverted to the acute care setting to work for 30 years in the surgical setting. She's bravely now stepped into the space of general practice and has rekindled her love of palliative care, albeit from a different angle. We've been working with Lorraine and her team at Conder Surgery, and they've been doing some great work in supporting palliative patients. So we've invited Lorraine to speak from a practice nurse point of view and how they utilise MBS item numbers and structure their support for palliative patients. Lorraine's not going to do a PowerPoint presentation. She's just going to talk from the heart about how they support palliative patients. Thank you, Lorraine. If you could just unmute, please.
There we go. Can you hear me? Hello, everybody. Thank you for having me. James, I was very in line with you with your talk. So what I'm talking about today is identifying and supporting patients approaching the end of life in the primary care, and also timely referrals to specialist palliative care. And I'll also pop in the MBS item number supporting a planned general practice palliative pathway. So I'm reading, sorry, just so that I don't make any mistakes. So at Conder Surgery, our GPs and practice nurses work together with our patients who are approaching the end of their life, and their caregivers as well. So Conder Surgery uses the MBS items supporting a planned general practice palliative care pathway resource to facilitate the support of patients approaching the end of their life and their timely referral to specialist palliative care. So the way we, with our identification of patients approaching end of life, obviously the GPs are, they have the medical expertise, but also our nurses come in very handy. And it's through our regular chronic illness health assessments and preparation of our GPMP care plans, the 965 and 967, with our reviews every 4 to 6 months, that nurses can develop a deep rapport with their patients. And oftentimes we can see or sense deterioration in our patients, and it might be physical, it might be mental or emotional. So at Conder Surgery, when patients are identified as approaching the end of their life, we've put together a nurse-led end-of-life care information package, which encompasses resources to support the end-of-life journey. So the pack contains, as much information as patients need, and including advanced care planning, health statement of choices, EPO information, where clinical and non-clinical help might be available. And I've found, and I think the other nurses have found, that these packs have really proven to open a dialogue with patients and caregivers who might otherwise shy away from end-of-life conversations. Dialogue that focuses on the end-of-life journey and not just resuscitation wishes appears to provide comfort in many instances, and provides a pathway for discussion for the patient and their family members. Quite often I've had patients say to me, "Oh, thank you, this is so good. It will help me talk to my my kids," So providing a care plan is in place, the practice nurse may also be utilised for monitoring and reviewing of a care plan, so a 10997. When patients are identified as requiring a referral to specialist palliative care, we conduct team meetings and case conferences. After discussion, a plan is formulated and acted upon, which involves all members of the practice. These meetings can occur at any time during the process, and that's a 735. So when patients are identified as approaching end of life, another activity includes the initiation or follow-up of a DMMR, as James was talking about with our consulting pharmacist, which is a 900. So often patients are more inclined to discuss more emotional issues with their nurses, and who we then alert our GP to with our concerns, our hunches, and patient wellbeing. This may or may not lead to a mental health care plan conducted by the GP, a 2715 or a 2717. So the way we refer to community specialist palliative care, the practice nurses play a vital role in identification of eligible patients, and thus facilitate the referral process when conducting annual health assessments, so the 705, 707, for patients over the age of 75 years. And quite often I will give them a pack even if they're not at that end of life journey, because I think sometimes they need a bit of a prompt to think about it in advance. And we also give it to we create the care plans for patients with chronic or terminal illnesses, the 965. I hope I'm not going too fast. I tend to get a bit nervous. Our mode of identification of timely patient referrals to specialist palliative care occurs in several ways. So at the head of the process, of course, are our GPs, who can refer directly to SPC for eligible patients with a clinically terminal life-limiting diagnosis. Alongside of that, practice nurses have a great opportunity to identify slight changes to patient health and wellbeing, which may be missed by the GP because of limited appointment times available and very busy workloads. We can identify early at any deterioration in patient health and wellbeing. We can identify patients that may benefit from home assessments rather than coming into the clinic. So that's something that we've started doing now. We'll go out to drive out once a month to some people's houses to do their assessments. And, you know, it's generally due to lack of transport, frailty or pain issues. So considerations when we refer to specialist palliative care, our patient referral criteria for the specialist palliative care are guided by the SPC referral form. So first and foremost, the patient must have a terminal clinical diagnosis for referral by their treating GP. We should be documenting their service providers that they have in place already. Family members in consultation with the treating GP may also refer. However, a provider number is mandatory on the form CH1417. So patient consent is required for the referral to take place after discussion with the treating GP, and consent is also required for sharing information with contacts. Other significant medical history is identified, including allergies, medication, mobility status. Social situation should be documented. Does the person live alone? Do they live with family? The reason for the referral must be documented. Carer details are required, including contact persons. Does the patient have advanced care planning in place? Staff safety requires careful consideration. And are there any psychosocial concerns? Are social workers involved, counsellors involved with the patient? So that's basically what we do. And I looked at Jane's suggested timeline after I wrote my little piece, and we follow that pretty much to a T, but not quite in the same order.
There you go. Must be onto something, Lorraine.
Yeah, I thought I was smiling all the way through yours. I thought that is excellent. And that's all I've got.
Thanks so much, Lorraine.
Okay.
I think, you know, it's really great to have a couple of champions in the primary care space. I know both Lorraine and James have been involved in supporting palliative patients. So any questions for either Lorraine or James, please?
I actually had a question, Ros, for Lorraine, if you don't mind.
Yes.
Sure.
Yeah, if Lorraine doesn't mind. Lorraine, so you said the nurses go out to the house. I mean, I think everyone gets really caught up on funding those. I think you can just do them just cause. It's like, do you go and then do part of a health assessment or do part of a care plan and come back and then
it's only we don't do the care plans. It's only the health assessments that we do, and it's only just something we've started doing recently. So I take out all the paperwork, you know, the mini mental, the depression scale, all the stuff that is involved in a health assessment. I do it by hand, then I come back and I just transpose it.
Yeah, I think
into their care.
Because I was even thinking you could even you could take a phone if the patient can't use like FaceTime or whatever. And you could book appointment with the GP and they could actually then you could telehealth it and you could actually do the item number on the day. But that's just I was
look, you know, I'm pretty proud of my going on about the numbers because it's not something that I'm really familiar with. So yeah, look, I kind of like to leave that up to the GPs to sort out. But I find that, you know, like we only do it once a month. It's generally me that does it. And it might only be one person, you know, and I found that, you know, that the patients really appreciate it. Particularly it saves them sitting in the clinic for an hour waiting, to get through it. It's more comfortable in their own home. So we're selective with who we take. Yeah.
Let alone what you can find out by actually going to a patient's house.
Yeah.
Actually.
Absolutely. Thank you very much. And I note that Conder Surgery has had a significant increase in completions and uploading of advanced care planning for their patients. So thank you very much for that. Lorraine, can you put in the group chat your Conder Surgery email if people have got questions that they'd like to contact?
So I just added in from here, yeah?
Yep. Just the nurse or the practice manager, Conder Surgery.
Yep, not a problem.
Thank you so much, Lorraine and
You're
James.
welcome.
That's awesome. Great. Thank you. So this leads really nicely into our next presentation. Our next presentation is brought to you by Dr. Emma Sharp. Emma is a senior palliative care registrar with Clare Holland House. And let me tell you, she is a whisker away of becoming a palliative care consultant at Clare Holland House. She's passionate about providing collaborative, high-quality palliative care. Emma has worked across all arms of the palliative care service, and she will outline these for us tonight, including what the services do, timely referral to specialist palliative care, and understand really what is the difference between primary palliative care and specialist palliative care and how the flow works between those. Thank you, and very welcome to you, Emma.
Thank you very much. I'm just going to get my screen shared. How's that look?
Yeah, perfect.
Great. So hi everyone. As Ros so lovely an introduction, I'm Emma. I'm one of the palliative care registrars working with Clare Holland House. And I really just want to thank Louise, James and Lorraine for their presentations, because it's been phenomenal for me to get an insight into how palliative care works in the primary care setting. I have the luxury of not needing to worry quite so much about billing items and things like that, but I think an appreciation of how those things can be best used so that we can provide the best care to our patients is so fundamental in palliative care. I'd like to begin as well by acknowledging the Ngunnawal people as the traditional custodians of the land that I'm presenting on tonight. And I find that rather than using a script that someone in HR has prepared somewhere, I like to use this acknowledgement that was written by my son when he was 8. So I'm lucky. I'm lucky to live in a magical place known as Australia, where we can run, jump and play, but all of that comes at a cost, one that not all follow. But I will, and I did, and that cost is to respect our elders past, present and future, and keeping the land as healthy as we found it a couple of 1,000 years ago. And when he said that, he meant we've come after the Aboriginal people. If we build on this land, we must keep their ancient stories they once told a couple of 1,000 years ago. We follow in their footsteps. It's Ngunnawal land, not ours. All I'm saying is I'm lucky to live in Australia. I'd like to talk just a little bit about palliative care in general. And I've got some pictures of two very prominent founders of palliative care. So on the left, we've got Dame Cicely Saunders, who opened the first modern hospice in 1967. And on the right is Dr. Balfour Mount, who coined the term palliative care in 1975. And Dr. Mount has just passed away quite recently. And Dame Cicely Saunders, I must say, trained as a nurse and then a social worker and then a doctor. So she was really right across the aboard in beautiful holistic care. And Cicely Saunders coined the concept of total pain, which is what we look at in palliative care. So it's not just the physical pain that someone experiences as a result of their terminal illness, but it accounts for the psychological, the spiritual, and the social factors that all contribute into how somebody experiences pain. Historically, the way that palliative care had been viewed is that when you're diagnosed with your terminal illness, you have very aggressive care and then it stops, and then you go to hospice care and then you die. And it was this very binary thing where you go from active treatment or you switch routes and you go down the palliative pathway. And we still hear people talk about that from time to time today, you know, oh, we're making them palliative now. But actually the model of palliative care that we use is now much more integrated. So recognizing that at the time someone's diagnosed with a terminal illness, they've got palliative needs often right from the very start. And an early introduction to palliative care is something that we know has actually got quality of life benefits, but also sometimes can result in extended duration of life. And of course, we see that as someone's disease becomes increasingly advanced, they spend less time with their other specialists, such as their oncologist, and more time with us because the focus changes, but we work hand in hand along the journey. So early referral is important, but how do I know when the time is right? One of the things that is really important is to recognize the different kinds of trajectories of deterioration that we see with different illnesses. And this is a diagram that I really like, which was developed by the College of General Practitioners. So there's a red line along the bottom that takes a diagonal turn upwards, and that's the extent of palliative care involvement. And then you've got three trajectories here that give a bit of an example of what we might expect with different illnesses. The blue line, trajectory 1, is the illness course that we often see with a cancer. And so someone might be reasonably stable at a reasonably high level of function, so functions along the y-axis there. And that might continue along at a fairly steady pace for a while, but then they start deteriorating. With cancer, we often see a reasonably predictable period of deterioration where people spend increasing amounts of time resting, increasing amounts of time sleeping, increasing loss of appetite, other symptoms developing. And those are signs for us that someone's entering their end of life phase and approaching the terminal phase of their illness. That's less predictable sometimes, or less easily identifiable with other illnesses. So trajectory 2 is an organ failure trajectory. So for example, COPD or renal failure, where someone might have a lower level of function from the time that we become involved. And then they have deteriorations and improvements. So they might have an exacerbation of COPD or an infection from their VAS cap. And they might become much more unwell, but then recover, perhaps not to baseline, and have a more gradual pace of deterioration with a more rapid deterioration in that terminal phase. The other trajectory that we do see a lot of as well is the dementia and frailty trajectory. And this is where having experienced GPs and involved nurses in primary care is so helpful, because when I meet someone, I meet them at a point in time and I don't have that longitudinal sense of how they've been going compared to previously. So this is why working together with primary care is so important, because in this trajectory 3, people can have a fairly low level of function that can be reasonably stable for quite an extended period of time. And it can be harder to pick when they're entering an end of life phase and approaching that terminal phase. And so you guys knowing your patients and linking them in at the right time is really helpful. But also, anytime you've got questions about, I'm not sure if this is right, we're really approachable as well and happy to have a chat as well. So there are sort of 2 components, if you like, of palliative care. So there's primary palliative care, which is everyone's business, which is managing symptoms that are not so complex, helping with shared decision making, helping communicate prognosis, establishing goals of care and advanced care planning, and focusing on quality of life. And that can be provided by a whole range of different members of the care team across multiple disciplines. And this diagram was taken from an article about pediatric heart disease, which is why they've got a lot of cardiac references, but everyone can do primary palliative care. Specialist palliative care, where we come in, is particularly focusing on the refractory symptoms, the really complicated symptoms, times when there might be really complicated psychosocial or spiritual distress, if there's conflict in families relating to palliative care issues, complicated decision making, transition to end of life, potentially transitioning into the hospice, and people who need really complex bereavement support as well. is provided by specialist palliative care. And so this is another diagram that sort of illustrates the way that the transition can occur. So for a lot of people, things can be quite straightforward and predictable, particularly with frailty and sort of multiple comorbidities at end of life. For older people, things are often reasonably simple and straightforward, and we can have a small degree of specialist palliative care involvement as needed, but a lot of the care is provided by other health professionals, which might be the GP, the nurses, perhaps staff in residential aged care, pharmacists, other allied health, doing the majority of the palliative care that person needs. As we move up the pyramid, you get patients where there's intermediate needs and fluctuating needs, and that might represent perhaps some of the people with the organ failure trajectories or more complicated symptoms from other illnesses like cancer, where they need, more of the specialist palliative care, but we still have the other members of the healthcare team involved in their care as well. At the pointy end of the pyramid, we often get people who have quite complex and persistent specialist palliative needs. And the one that I really think of in this case is the people who've got advanced cancer in their 20s and 30s, where there's a lot of that total pain from all the domains coinciding at once, and we need a really specialized team to be doing the heavy lifting and caring for people in that stage. But I think this the shading this diagram is used doesn't do justice to the fact that actually we still need the rest of our care team involved as well. So to talk a little bit about how that happens in Canberra, I'm going to describe some of the services that we've got through the palliative care services in the ACT. And to begin with, I'll talk about our outpatient clinics. So these are held either at Clare Holland House or the Canberra Hospital. So these are for ambulant patients. They might still be going through their chemotherapy or radiation therapy with specialist palliative care needs. We don't take over management of chronic pain that's not related to a cancer, even if someone has a different terminal illness, except in the final days of life. There's a different approach to managing chronic non-cancer pain to the way that we manage cancer pain and end-of-life pain. So that's an important distinction to know about. Where possible, if someone's having other treatments at the Canberra Hospital, we try and get them booked into the clinic there, and we try and coordinate their appointments with, say, their oncology appointments and things like that, just to make things a little bit easier rather than having to go to different places at multiple times. And Canberra Hospital will also selectively see people that they've gotten to know when they've been unwell in hospital, because then there's that continuity of care as well. And there is an aim to develop some streamed clinics. So rather than just this is the palliative care clinic, it might be, well, on Tuesday we have a breathlessness clinic, and on Thursday we've got an oncology clinic, but that's a bit of a work in progress. We are trying to transition to a more streamlined referral pathway, and the HealthLink referral form is currently being updated, and we are updating the referral guidelines and education resources as well, which will hopefully mean that for those of you in primary care, you don't need to decide which of those services you want someone to go to. We can do a triage, and we can work out when the next appointments are, and we can contact the patient and talk through the options. The other outpatient clinic that we support is the motor neuron disease clinic. This is based at the University of Canberra Hospital for patients with motor neuron disease, which is a progressive degenerative neurological disorder where people have really very complex needs. And this is very allied health heavy in terms of the staff that we've got there, because that's really fundamental to good care for patients with motor neuron disease. And we do have palliative care medical support that goes along and is involved in that as well. We also have the home-based palliative care team. Now, a lot of the time I hear people say, oh, you know, but they get tired and they'd really prefer not to come out to a clinic. Could you just come to them? It really is something we don't like referrers promising in advance to people, because as with all things in healthcare, we've got a limited range of people on our home-based team. And so for people who are well enough to be going out to their oncology appointments and still having chemotherapy and things, we do get them to come into our clinics as well. Home-based palliative care is really more for the people who are in their final, usually about 6 months of life, who have goals of care that are for maybe hospital if there's something easily reversible, but not for advanced interventions such as intensive care or CPR and life support. And what we provide is that 24-hour support for symptom management and end-of-life care. Sometimes you'll get a patient for whom, like, you can see that they're approaching end of life, but they're really struggling to come to terms with limitations of goals of care and things like that. In those cases, pick up the phone and give us a call, because we do make exceptions. But broadly speaking, if your patient wants intensive care and they're more breathless at 2 a.m, the answer isn't to give more symptom management. The answer is probably to go to hospital and get assessed. And so that's why we try and be careful that we're not inadvertently giving someone advice that limits the treatment options that they're wanting to have. So our team in home-based palliative care do home visits and phone support, and the frequency depends on where someone's at in their illness and what they need. It is a multidisciplinary team, so we've got really skilled palliative care nurses, we've got physiotherapists and occupational therapists who are very experienced in the palliative space as well. We've got social workers, we've got our pastoral care team, we've got a nurse practitioner and some doctors as well. The home-based palliative care team does operate within the confines of the ACT only. There are different services available to people who are in Queanbeyan or Googong and Jerrabomba and so on. It's important to note that home-based palliative care is not an emergency service, so we might only have 2 nurses on a weekend, and if they're in Tuggeranong and someone in Gungahlin has a crisis, we can't just get there instantly. We don't take over the care of GPs. Occasionally someone who's a palliative care doctor might also be a GP, but that's not a universal thing. And we don't go and do the acute medical assessments of, does this person have a UTI? Does this person need an X-ray because they've had a fall and they've now got, you know, ankle swelling? We don't take over those types of things. We also don't provide personal cares, but our social workers can link people in with supports and things to get personal cares set up at home. Again, we don't manage chronic non-malignant pain. There's better avenues for that. And I guess the other thing, particularly while we're still working on finalising our new referral form, the more detail we get in the referrals, the better, particularly about what the person understands about their prognosis, what the goals of care discussions have been, what you've done so far, so that we're not duplicating pharmacy medication reviews and things like that. So all of those things are really helpful. We do read them really closely. We also have the PEACE team, which is Specialist Palliative Aged Care. This is a team that go into residential aged care facilities to provide specialist palliative care input there. Sometimes people have only got primary palliative care needs and their end-of-life care is quite straightforward, and that's able to be managed by the GP, and that's fine. We don't need to be involved in every person who's approaching end of life if the GP feels confident and comfortable managing that. But oftentimes we are involved, we support the GPs, we give advice about medications and things like that. And for people who've come into a residential aged care facility for respite, which team looks after them really depends on whether they're expected to return home or if they're going to become a permanent resident of the facility. So if they're going to go home, we get the home-based palliative care team to be involved. If they're going to stay in the residential care facility, we get the PEACE team to look after them. And the reason just being that we like to focus on continuity of care where we can. The next component I'll talk about is our inpatient consultation teams. So, of course, people with terminal illnesses quite frequently end up in hospital. And we've got consult teams both at the North Canberra Hospital and at the Canberra Hospital, where we go and see the person who's admitted under the medical team or the surgical team and provide that specialist palliative care recommendation and advice. So at the moment, we're not the admitting team yet, and I'll elaborate on that. So we're just providing advice. And there are also the opportunity for specialist palliative care consultations in the private hospitals as well. So this is a view from the lovely place that I've got the privilege of working, Clare Holland House. So Clare Holland House is a short-term specialist palliative care facility. We've got 27 rooms. We're not funded for nurses to have 27 patients at the moment, because when we build the extension, we're future planning, not just for what we need right now. We bring people to Clare Holland House, sometimes for symptom management with a view to getting that stable and returning them to their normal place of residence. Sometimes for end-of-life care, where we're expecting someone to come in and pass away in Clare Holland House. And we would usually take people for that type of care if we think that they're in their final, 2 to 3 weeks of life or less. It's important to know there's limitations on what we can do at Clare Holland House. So we don't have doctors on site around the clock. There's always a doctor on call, but we're only on site between 8 a.m. and 4:30 in the afternoon. We don't have advanced life support services there. We don't have MET calls because we don't have an ICU. We're not co-located with the hospitals. And so if someone is wanting full resuscitation like CPR and they need symptom management, Clare Holland House might not be the safest place for that to be managed. And we might suggest that that's done in an acute hospital where they do have those escalation pathways. We occasionally do take people for respite, but only in very specific circumstances. So we take people who've got very complex palliative care needs where there's no other alternative respite opportunity for them. So motor neuron disease is a good example. Sometimes for people who've got very high care needs with a cancer and they're under the age of 65, so they're not eligible to have respite in residential aged care. These are never emergency things, and it is always booked in advance by our social work team. I thought I'd mention briefly pediatrics. Fortunately, we don't have too many children in Canberra who need specialist palliative care due to our population size. Because of that, though, we don't have pediatric palliative care specialists in Canberra, and so we get support from Bear Cottage, which is run by the Children's Hospital at Westmead. We do have a pediatric palliative care specialist nurse who's based at Canberra Hospital, where obviously the pediatric service is, and she gets supported through Bear Cottage as well. We do sort of on a case-by-case basis some support with the home-based palliative care team, but that's always have a chat with us if you've got someone for whom you think that's needed. And sometimes we do manage or support children with terminal illness via the clinic at the Canberra Hospital, and that's usually in conjunction with the paediatric palliative care nurse and the paediatricians, so a more holistic thing. We don't see them in the clinic at Clare Holland House because we're adult medicine doctors, and so we try and keep it co-located with paediatrics so that it can be that team-based care. I wanted to also mention our wonderful volunteers who run some incredible services, one of which is pictured here, Leo's Place, which is a place to rest a while. this is a place where people with palliative care needs can have some respite. They do need to be able to care for themselves, including independently toileting and things like that. And they can either stay for a couple of nights, or it can be just a day program, and that can be coordinated through Palliative Care ACT. They also do volunteer support at home, which isn't personal cares and things like that, but they can, you know, make an easy meal or a cuppa. They can take someone out for a social outing. They can do hand and foot massages. They can spend time and company with people. The volunteers also do some wonderful work at Clare Holland House with a breakfast trolley for the hot toast in the morning and a drinks trolley in the afternoon. And they can also see people in residential care. They've got a great program where they've got specially trained volunteers who can sit with people and help record their life story. And they also do bereavement cards for people who've been part of the palliative care service 6 weeks and 12 months after they die. And so in case any of our lovely volunteers are in the audience, thank you so much for the work you do. And then just acknowledging everyone who works in primary palliative care, GPs, nurses, community nursing, NDIS staff, aged care providers, and community options, because we can't deliver the care that people need on our own. It's all part of a team. And some upcoming changes as we move forward with palliative care in the ACT. As I mentioned, we're streamlining some of the referral pathways. We're also really conscious that voluntary assisted dying is coming into effect from next month. And so while that's a separate service, the people who will pursue the voluntary assisted dying pathway are all legally required to be offered palliative care, and they certainly ethically should all be offered palliative care as well. And we know from other jurisdictions that the vast majority of those people will be engaged in palliative care as well. And the last thing that we've got that's quite active on our radar is the development of an acute palliative care unit based at Canberra Hospital. So this will be a 12-bed specialist inpatient palliative care service for people with very complex needs, and particularly those people who've still got quite active goals of care but might need a nerve block for pain, or they might need a ketamine infusion where they might need some cardiac monitoring because they're still very active with their goals of care. That's currently being built. We're still waiting on operational budgets and things like that. So this is a bit looking forward probably into 2027 at least, but is an active work in progress. And so I think that's enough of my voice for the moment, but if anyone's got questions, really happy to have a chat.
Thank you, Emma. Thank you. Can I invite questions from the audience, please? While you're writing in the Q&A box, one of the things I'd like to mention is also in the community nursing team. There's one specialist palliative care nurse. Her name is Jackie Boucher. And that is, she sits in the community or primary care setting and supports the nurses caring for patients that may be approaching end of life, that haven't been referred to or need to be referred to specialist palliative care. That is just one nurse for the whole of ACT, but she works very closely with the specialist palliative care teams. And a bit like what Lorraine was talking about, often the community nurses are the ones doing the home visits and seeing the patients deteriorate. They may not be involved so much with anyone outside of their home clinically, GPs or specialists. So that team is very important in also screening for palliative patients and noticing deteriorations that the clinicians may not be aware of. And Jackie too is also working hard in the advanced care planning and goals of care discussions. So I just thought I'd add that in there because that's another space your patients might be starting having palliative care and end-of-life discussions. Thank you. I've also put in the chat some of the resources that have been referred to. Is the Silver Book from RACGP. I've put in there. I've put the link to HealthPathways. I've also, Lorraine's popped in her email, and so has James. The other thing I'm going to pop in the chat is a resource page for GPs that you can access that has a lot of different tools and apps that you might like to download. One of the apps that I know GPs find really helpful is the PalliMeds app. That app is a very simple tool which covers the basic medicines for pain control, nausea and vomiting, breathlessness perhaps. So that app, I know the GPs at Conder Surgery are using it, and certainly JMOs around the hospital often refer to that as well. So that's it from us. The presenting team, have you got any additional comments or questions that you have for the presenting panel? All right.
I had Emma did such a lovely job of acknowledging everyone that I should have acknowledged Jenna Ingram, who is the Deputy Medical Director at Clare Holland House and helped us develop the health pathways that we have done so far.
Excellent. Yes, thanks, Louise. That's great. Thank you. So this is session 3 of a 7-part webinar series. The series has been developed to coincide nicely with the introduction of voluntary assisted dying in ACT, so we can ensure that end-of-life care and all the different components that need to be thought about are covered and you have access to that information. This series is being recorded and will be available on the CHN YouTube channel. So please continue to register for the webinars, and even if you can't attend on the night, you will have access to the remainder of the webinar series. We've had really great response and registration. We will be sending you a survey, which is really important for you to complete because it helps us as a team here at CHN work out what's important to you. If we don't know that, we can't address what you would like to know or want further information on, and also how we can adjust whatever we're doing, the seminars we're providing, the programs that we're looking at to support you better in supporting your palliative patients. So thank you so much to the presenters. Thank you so much to the participants for joining. Thank you to our Kunal behind the scenes, managing and running the event. He's our education lead at Capital Health Network, and he does a super job. So thanks, everyone. Have a great evening and keep up the good work. Thanks, everyone. Good night. Have a good evening.